Hello, it's a pleasure to be with you. I appreciate very much the invitation from Professor Ha and the other organizers to invite me to participate in this continuing medical education event. I'll try to speak slowly and clearly so that you can understand my English, and hopefully our translators will have done a very adequate job, because tiếng Việt của tôi thì rất là kém và tôi không được truyền bày hết bằng tiếng Việt hôm nay. So my purpose in this presentation is to update you on some of the thoughts that are going on with regard to molecular classification in endometrial carcinoma. But I will emphasize that this is an ongoing process. First, I'd like to just say that I have no financial relationships pertinent to any of the testing, any of the antibodies, any of the other materials that we'll talk about today. And I'm purely presenting this as a hope to update you on the science and help you to get your understanding about how you can improve your practice to provide better information for your patients and your clinicians. There are three main objectives that I want to have you leave this presentation with. One is understanding these four major categories of endometrial cancer as defined by molecular features, and recognize in association with that the significance clinically, treatment-wise, for being able to classify them using this method. And finally, to help you recognize some of the surrogate testing that might be available to you to begin to apply this in your practice. Now, my children, when they were growing up, loved to put together models using these plastic blocks. In the United States, they're called Legos. Actually, they're international. But I know that individual Lego blocks are like pieces of data. They're very painful sometimes if you step on them in the wrong place. When they're sorted, arranged, properly stored, and even better, when they're prepared into a coherent structure, they can tell a wonderful story. And that's what I hope you leave with today, is some understanding of the story that goes with the data, which is quite extensive. So when the WHO classification was updated in 2022, we noted that there were now 4 molecular subtypes that were included in the group of endometrioid carcinomas, along with more conventional types of carcinomas that we had known for a long time, including serous, clear cell, mesonephric, squamous, et cetera, et cetera. However, in fact, these molecular subtypes have implications across these other types as well. And the evolution of this began with the Human Genome Atlas, and then ultimately drew more extensively out of the Cancer Genome Atlas, which took genomic and transcriptomic as well as proteomic features from a large number of endometrial carcinomas that had very good clinical follow-up data to create 4 main groupings. And these seem to fall together in a natural way because they had both prognostic and, in many instances, therapeutic implications. The latter only seem to grow more extensive. Now, the first division was looking just at somatic copy number alterations. So looking at those with very few additional chromosomes, those cases do very well. You get a few more, and you begin to fall into these other groups until finally the very increased number of copy numbers implies poor prognosis and a bad outcome. Well, looking a little further at these groupings, they began to look at what are the transcriptomic features that are going on. Where are the mutations happening? What's going on? And what are the pathways that are activated from a proteomic or other standpoint? And we began to see that there are a couple of major pathways that are involved: the RAS beta-catenin RTK pathway and the PI3K pathway. all seem to have varying levels of activation or inactivation of various key genes that lead to proliferation, increased cell survival, and so forth. And here you can see what the specific genes were and their relative frequencies in different of the cluster mutations that we'll talk about later. SOX10 mutations and so forth. And as you begin to group these with some of the other features, you can again see these differences. Noting here, however, that some of the groups, such as those that associate with estrogen receptor or P53, may be quite variable across some of these groupings, but tend to have some clustering here as well. So while I'm not a molecular pathologist and I don't want to give you a great deal of the specifics on these issues, this is data that we have to begin to apply and use. When we looked at gene expression, either low in the green cases or high in the red cases, we can again see these groupings begin to cluster. And doing so according to particular genes that were overexpressed or lowly expressed, or so forth, in various ways. And these began to then cluster into particular groups with messenger RNA and protein expression profiles that were distinct from one another. Now, this next slide, a very busy slide. I apologize for that, but there are some important things that this tends to bring together that I think will emphasize a couple of key points. So one of the key points is that this brings together the somatic copy number groupings, as you see here, the tumor histology, tumor grading, as well as some of the specific key gene mutations and or epigenetic changes that may be present in these cases. So, for example, if you look at tumor mutational burden, one of the first groups is these POL ultramutated groups, which have very high mutational burdens. And as we look at these groups, we can see, well, they have a high number of POL mutations, rarely some of these other mutations, but notice occasionally this group also has TP53 mutations as well. And oftentimes they're high grade, but they typically have endometrioid histology. If we look, on the other hand, here at the copy number high, also a relatively common grouping, the serous-like or serous tumors, you can see these have very prevalent TP53 mutations. They tend to have serous histology, and they tend to be high grade. So this may be a fairly easy one from a morphologic and immunohistochemical standpoint to begin to identify. These other two groupings, the MSI, also have hypermutations, not as high as the POL group. And the copy number low groupings, endometrioid tumors, likewise have relatively lower mutational burdens. Another thing to note here, as we look at the patient cases with mismatch repair defects, the MSI high cases, you'll note that a large number of them have this solid green bar, which represents DNA methylation and silencing of the MLH1 gene. So there's more information here, but I think that's enough to draw from this. But the other thing to be aware of here is that there are huge differences in survival, especially when you look at these POL groups, this first group, hypermutated, in comparison with the copy number high or serous-like tumors, which have maybe 50% survival long-term. Now, we know that serous tumors and TP53 mutations are not unique to the endometrium. They also occur in the ovary. Some breast tumors, notably the basal-like tumors, have high frequency TP53 mutation. And so they naturally looked and compared these various tumors to compare what was going on in terms of chromosome copy numbers and so forth, and various specific gene mutations. And while there are some similarities in certain chromosomes and so forth, there's also quite a bit of noise here and quite a bit of variability between the breast tumors, the ovarian, serous tumors. Now, we don't apply this yet between differentiating synchronous or simultaneous separate primaries in the ovary and the endometrium, but it has some potential in that regard. So this sort of leads us to kind of the basic nomenclature of our 4 groups. And you'll hear a variety of terms used. So whole groups, this stands for DNA polymerase epsilon, so POLE. This is the ultramutated group, and those are all kind of synonymous. The MMR deficient or mismatch repair deficient, these are also sometimes termed the MSI high, depending on the test that's used to define them. The TP53 mutant group or P53 abnormal also corresponds to the copy number high group. And then finally, we have the no specific molecular profile group or the copy number low group. And these terms are based on a couple of different studies that use slightly different methodologies to define them, but came up with really quite remarkably similar survival curves for both of these, for these groups. And so, as you see here, the P53 abnormal or mutant group has the worst prognosis. The POL mutant group has the best prognosis. Wild type P53 corresponded to the no specific molecular profile group, and the mismatch repair abnormal or MSI high group was somewhere in between. So this information is quite helpful. These 2 studies, the PROMISE study and the Leiden study, had fairly respectable numbers of patients enrolled. And so this is fairly robust data for what to expect. So as we look at these molecular subtypes, let's start with the first group, the POL ultramutated group. And this was a relatively small percentage of the TCGA study group. As we look at the classifier and so forth, these tumors tend to have very high mutational burdens, low copy numbers, high frequency of P10 mutations, and as indicated here, they can often be high grade. They'll have lymphovascular space invasion and other very aggressive features. But they also have some prominent tumor infiltrating lymphocytes and so forth. They tend to be younger women, maybe thinner, but in contrast, the outcome is very favorable. So what happens if we don't identify these patients prospectively? Well, we could certainly end up with overtreatment. We could certainly end up with poor utilization of resources because of this, and patients who would be misinformed about the prognosis and thus make poor decisions. And likewise, because these patients may be susceptible to checkpoint inhibitor therapy, remember they have a lot of tumor infiltrating lymphocytes, we might overlook that possible treatment option. Well, let's look at the MSI or hypermutated or mismatch repair deficient group. These typically also often have P10 mutations and other mutations, relatively low copy numbers. They may have tumor infiltrating lymphocytes and high-grade features, but they also not infrequently have some Lynch syndrome association. And therefore, their response to radiation or other therapies is somewhat different. So what if we fail to identify this group because we didn't do testing for MSI or mismatch repair? Well, first of all, we'll miss any potential association with other tumors, GI tumors, other kinds of lesions that they can have, and therefore we might miss opportunities to detect second, third, and fourth cancers that could have been detected earlier. And we might likewise fail to screen family members that might similarly be affected. And the lost opportunity to use immunotherapy. Finally, let's look at these copy number low versus copy number high groups. This is the p53 wild type versus p53 abnormal type. And I'll point out here that one of the surrogates for this type may be estrogen and progesterone receptor, which tends to be very strong. And so this may be a little bit of a thing to keep in mind. That's a difference. The p53 mutational status, of course, is different. But here again, the therapy can be quite different because many of these TP53 cases, mutant cases, may be susceptible to HER2 targeted therapy and chemotherapy. In contrast, hormonal therapy may be more effective for these copy number low cases, and certainly very different prognosis. So again, what if we fail to differentiate these? Different prognosis, very different treatment choices. And finally, yeah, I mentioned the chemotherapy can be quite different for these tumors. Well, so if we're going to do p53 testing, we want to ask the question, how do we differentiate, or what is the difference between a TP53 mutation in an endometrioid type tumor versus a serous tumor? Or are really all p53 mutated endometrial cancers just serous types that we haven't sampled well enough or haven't defined properly? And if we look at these different subtypes, these were all classified as endometrioid type tumors, at least these first three. And you see here is a grade 2, grade 3, and these don't look particularly serous. Here's a grade 3 tumor that's nearly solid, might be kind of serous. And sometimes these have kind of ambiguous features. Occasionally, even clear cell carcinomas can have TP53 mutations. And sometimes the expression of TP53 can be somewhat subclonal, perhaps we could say, partial areas, as you see here, some areas affected, others less complete staining patterns. So as these cases have been more fully evaluated, the outcomes are quite interesting. So this was a fairly good-sized study of, as you can see, probably almost 200 TP53 positive tumors, of which the majority were uterine serous carcinomas, as you see here. And the ages you see here, and here's the stage at which each of these presented. The typical serous carcinoma is a higher proportion at high stage, as compared to clear cell carcinomas or endometrioid type tumors, which may have tended to be at a lower stage. And as we look at kind of, did they have myometrial invasion? Did they have peritoneal spread? As you see, some of them did. And was there recurrence? Well, a fairly high number, about 25–30% did, and so forth, compared to those who did not. But when we look at survival between those that were called serous and those who were just other histologic types, the TP53 mutation is not good news, and they tend to have poor survival. These are the therapies that were offered to these patients and so forth, and the relative outcomes as you see in that situation. So endometrioid histology, serous histology, probably not a huge differentiator, but the presence of TP53 mutation is a significant differentiator in outcome. So let's ask ourselves the question of how good is p53 staining by immunohistochemistry at evaluating the TP53 mutation status. So this is a nice study from several years ago showing the different immunohistochemical patterns. There are 4 different patterns that are recognized, and here you see them over here in these different categories. And here we then looked at these cases, about 200 cases, to see, 250 cases actually, to see what mutations were present. And as expected, the overexpressed nuclear overexpression is the most frequent. And fortunately, when we look at the evidence of no demonstrated mutation, all of those patients had a wild type expression. So just what you would want. This is very high negative predictive value, let's put it that way. However, I will point out that there are some cases where we have wild type expression and we can have a mutation present. They're rare, very small minority of cases, 7 cases out of, probably, almost 200 cases or 175 cases. So it's, less than 5%, less than 1%, but it does happen. Just to review, these are the 4 patterns that we can see and are defined. Diffuse overexpression, strong nuclear expression in greater than 70% of the tumor. This is the null type. And with the null type expression, you should see 2 things. You should see negative, virtually absent expression within the tumor cells and good expression in the stromal cells. If you don't have both of those features, I'd be very careful about calling a tumor a null type pattern. A third type that has mutation is the combination of both nuclear and cytoplasmic staining. This is the least frequently encountered pattern, and it can be missed on occasion or misinterpreted on occasion. I've seen that happen. And so that scenario you should be aware of that, so that on the rare case that you see that, you don't think, oh, this is aberrant staining or not normal, but it's not mutated. This is a mutated pattern to have overexpression in the cytoplasm and the nucleus. Now, this is probably a wild type, but it's really kind of upregulated from what the usual wild type is. But you have heterogeneous staining, some strong, some weak, some not at all. And that should fit into the wild type category. Usually there's far less staining than this, but this is still a wild type pattern. Now, there are some challenges and some pitfalls. And I've mentioned one of these is the wild type versus null staining. So here you can see, is this null staining or is this wild type? The staining is very weak. And so if you're not certain, you need to be careful, and maybe it's uninterpretable. Here's another type where, it looks like we've got pretty good stromal cells, and I believe this is non-expression in the tumor, but it's a little bit iffy here too as well, and it may not even be tumor. Some of this may be just benign glands. And then you can have, overexpression, cytoplasmic, nuclear staining, and so forth, as you see here, but overstaining is also possible. So this is just a case that's overstained. You see the stroma is positive, the cells are all positive, and these are relatively benign glands. Whereas this is probably understained cytoplasmic and nuclear staining in that mutated pattern. So this is not a stain that cannot be just ignored. So how do we report this? Well, we will report the staining pattern, complete absence, null type, diffuse overexpression, or dense cytoplasmic and nuclear staining, wild type staining. And how we report it is diffuse overexpression consistent with mutated status, or mutated pattern, null type, or wild type. Obviously, we would also report cytoplasmic and nuclear staining consistent with mutated status as well. Now, as if that wasn't enough, there are some other circumstances where P53 can be confusing. And those are situations where you have so-called clonal or subclonal patterns of staining. Here you see nuclear overexpression in one area and a more wild type or upregulated pattern here. Here we see nuclear and cytoplasmic staining with more maybe upregulated or diffusely positive staining, so different staining patterns of this, both mutated. And here's one null, one mutated type here. And so different staining patterns may indicate different subclonal populations of different mutations, or subclonal populations with mutation and other populations with wild type expression. In general, these situations are uncommon, but when they occur, they can be problematic, and the interpretation is not always straightforward. But in general, the majority of these have either been pole mutated cases or cases that will behave as conventional endometrial carcinomas rather than the TP53 dominant mutation, which is a little bit unusual and perhaps less than what you would expect, because we usually expect the driver mutation to be the worst mutation. That's not always the case. So how are we going to apply this? Well, there are a couple of scenarios that have been proposed. So one way to do it would be to sort of follow the TCGA classification method and first do pole testing. And if it's positive, then you've got your answer. If it's negative, you go down and do MSI testing or MMR testing to see if you've got a hypermutated, and if not, then you would do copy number alterations. Well, I don't know any laboratories that are equipped to do this easily, and so this is not widely applied. Under the PROMISE group, they applied it this way. They looked first at mismatch repair proteins, and if they were deficient, they put it in that mismatch repair group. If they're proficient, they then went to pole mutation. If that was missing, they termed it unclassified. Or if it was mutated, then they stopped there. And then finally, they would do P53 mutation. Well, again, if you don't have pole mutation capabilities, you're going to end up with a lot of these unclassifiable groups. And the reason why this comes in here, of course, is because we know that there are some pole mutated patients who will have TP53 mutations. And so that in an effort to avoid that misclassification, this really does belong here. In a real world situation, however, doing some combination of these markers is probably prudent. So for example, in our laboratory, we will do a panel that consists of mismatch repair proteins, P53 immunohistochemistry, and ERPR. If we get strong ERPR staining, we generally will put those in this no specific molecular profile, especially if we've got a normal TP53. If we're negative, or we have some other abnormality in these TP53 patients, we then might look at the possibility of doing pole testing. But that's, at this stage, it's still fairly costly for us and not widely available. We're trying to get there. Let's talk a little bit more about the immunohistochemistry for mismatch repair defects. I don't know how many of you are currently doing these routinely, but we essentially test all of our endometrial carcinomas now using this methodology of immunohistochemistry. As you know, these proteins are grouped. And so these are heterodimers. The MLH1 gene, if that's absent, you'll see neither expression of MLH1 or PMS2. And likewise with MSH2 and MSH6, if MSH2 is defective, then MSH6 will also be unexpressed, cannot be expressed. There are a few cases where you have isolated PMS2 loss or MSH6 loss. Those are very highly associated with Lynch syndrome and may indicate the need for genetic testing. When we see loss of MLH1 or PMS2, or excuse me, loss of these two together, we will routinely do testing for hypermethylation to verify that this is not Lynch syndrome in our population. So that's the simple method of doing those. But of course, these are not readily validated because these are predictive markers with significant therapeutic implications. Ideally, you should have 20 positive and 20 negative cases to validate these with 90% agreement with your validated reference value. Now, you can validate the immunohistochemistry using MSI testing as your standard, or someone else who's validated their immunohistochemistry you can use materials from them. And anytime you discover discordant results, those need to be investigated before you put that assay in service. So here's essentially how it might go in terms of evaluation. So we do immunohistochemistry using the 4 markers. If they're deficient and it's MLH1 and PMS2, then we will do hypermethylation, as I've mentioned. If it's non-methylated, they go to genetic counseling or genomic testing to exclude Lynch syndrome. If it's methylated and there's no family history, those patients are treated potentially with immunotherapy agents or so forth, and but if they're younger, then they may have an epigenetic inherited defect, and that family history may be worth pursuing. In contrast, if they're proficient and there's a positive family history of endometrial cancer, again, some genetic counseling may be warranted in these circumstances. So in general, the problems that we're going to encounter if we can't apply all of the steps of these algorithms are likely going to be in this middle ground, where there's mixed tumors, where we have a low-grade tumor with a TP53 mutation, or where we have a high-grade endometrioid cancer, some of the carcinosarcomas with maybe an endometrioid-like mutation protein profile and so forth. These are the areas that are going to be problematic and where our molecular profiling really is most necessary. If we can identify serous carcinoma readily on histology, almost don't even need to do P53 staining. Likewise, with many of our low-grade tumors, those are most likely going to be the type 1 tumors that are going to be in the no specific molecular profile group. Now, let me just make a note here with regard to intraoperative evaluation of endometrial carcinoma. Now, ideally, these patients have a prior diagnosis, curettage, and so forth. And if it's high-grade carcinoma, intraoperative evaluation is not going to be particularly helpful. Those patients need to be staged with lymph node sampling and so forth. If it's a low-grade endometrial carcinoma, then there may be some room for differential treatment of these patients. So larger tumor size, those probably should get lymph node sampling. And you may know this from staging studies, ultrasound, et cetera. If they're smaller tumors, well, that's where doing a frozen section may be pertinent. And in that circumstance, we want to look for tumor grade. We want to look for depth of myometrial invasion, and of course, any evidence of lymphovascular invasion. If we see any of those higher risk features, then the patient may benefit from lymph node sampling. Now, if your institution is doing sentinel lymph node sampling and the nodes map using sentinel sampling, then they won't need to do frozen section evaluation because once you get the uterus out, it's too late to do mapping for sentinel lymph nodes. So if you're going to do sentinel lymph nodes, then frozen section doesn't become very helpful in these cases. So let's just go back to histology. We're pathologists. We love to look at H&E stains, and we know how to recognize, low-grade endometrioid, higher-grade endometrioid. We know how to recognize serous carcinoma, clear cell carcinoma, and we grade these. And we also know that these histologies have certain associations with spread, with prognosis, and so forth. And to some extent, they have fairly recognizable patterns of expression of molecular markers, such as the estrogen progesterone receptor that I mentioned earlier, or p53 expression, and so forth, Ki67 rates, and so forth. But these low-grade tumors are mostly going to be no specific molecular profile. But there will be some mismatch repair deficient and a few POL cases. The higher grades will also have variable categories. And so separating out the different treatment and prognostic categories purely on the basis of tumor histology and grade is going to fall short on a number of occasions. P53 is perhaps more useful and can help you to separate out prognosis, certainly, and some of the treatment modalities there. But again, you'll miss some of these POL cases because some of those may hide here in a P53 mutant cases. This graph, I really like this graphic because it helps you to sort of see that, the majority of our low-grade endometrial carcinomas are going to be the copy number low or no specific molecular type. But there will be some POL cases. There will be a few MSI or MMR deficient cases. In contrast, when we look at serous carcinomas, well, these are almost all going to be in the TP53 mutated category, but there are some other tumors that are also in that TP53 mutated category. Some high-grade endometrioid tumors, some mixed carcinomas, some carcinosarcomas, and even some clear cell carcinomas are going to fall into that TP53 category as well. So you have to be thinking in a multi-dimensional manner to figure this out. And of course, that's because the molecular machinery that's going on inside the cell is so diverse. It has lots of parallel pathways, lots of different interacting genes that all can be involved in the pathogenesis and can be expressed and tested for in various ways, and sometimes treated based on what's going on in the cell. And the more granular understanding we have of what these things are, the more useful we can be as pathologists in providing the right prescriptive treatment for the patient, whether that's a P10 inhibitor or some other ARID1A inhibitor or whatever it might be that can be used as a targeted therapy. So let's be pragmatic here. And I know that not all of you practice in a highly proficient reference laboratory academic center, and your resources are somewhat limited. So let's say that you just have routine histology. You can still do a lot. Pay careful attention to the nuclear grade, and things that are high nuclear grade, be thinking about the possibility of TP53 mutated tumors. Apply the grading criteria carefully and look for the features of serous carcinoma or clear cell carcinoma or high-grade endometrioid tumors, because separating these things out will provide some stratification by possible applications. Now, if you can do immunohistochemistry and you have a reasonable volume of endometrial cancers, I think it makes very good sense for you to do these three categories of tests. So do your P53 stain, validate that, validate your mismatch repair proteins, MLH1, PMS2, MSH2, MSH6, and estrogen and progesterone in quantitative fashion. This is not just qualitative testing, but quantitative fashion. And ideally, if you're going to do P53 stains and classify serous carcinomas, and your institution has access to Herceptin or other HER2 inhibitors, then you should add HER2 testing to this panel for any TP53 mutated case. And this should allow you to identify most of the copy number high, the mismatch repair deficient, and no specific molecular profile groups. You will have some overlap with the POL groups between the P53 positive or mutated category and some of your high-grade tumors. But this is better than nothing. And in fact, this is essentially what we do now in our laboratory because we don't have ready access to POL. So what do we need to report? Well, as you report, these are items from the C8B checklist. They include the operative procedure, the specimens removed, histologic type, which will, of course, include the several molecular profiles, but sometimes not otherwise specified. Endometrial carcinoma, not otherwise specified. You should report grade, depth of invasion, staging information like cervical or adnexal involvement, serosal involvement, omental involvement, and so forth. And then as optional features, recognizing that the extent of lymphovascular invasion, the pattern of invasion, whether it's, the so-called MELF pattern where you have fragmented, partially angulated glands, that pattern is somewhat predictive, and whether or not you have lower uterine segment involvement. Those can be helpful factors, but mostly in terms of, do we need to do staging and so forth. So with that, we sort of come to the end of this, and hopefully the story makes a little bit more sense now. I know we've still left a few pieces maybe straggling around in the backyard, but I look forward to taking your questions and sharing whatever may not yet be clear. So thanks very much for listening to this point. And with that, I'll stop the share and look forward to your questions.